Bismillahirrahmanirrahim. Okay, this session is about how to approach the case scenarios when it is given in the form of MCQs. When it's given in the form of MCQs, inshallah, you will be encountering this kind of style of examination, and until you go to residency, even in the residency, they are bringing this kind of examination. Okay, now, so I'm going to discuss how to approach. This is the systematic approach when any case is given. When any case is given. So inshallah, after this session, you can able to dissect the case into three components. Okay. So these are the major components. One is case history. Okay, the patient's history details will be there, and clinical findings, examinations will be there. Clinical examination findings will be there, and lab investigation results. The lab investigation results or findings will be there. So when you can able to dissect this case, when you see a case, your brain has to immediately split them into three parts. Okay, so it's not like you have to take notes of it. Okay, you should develop a art. You should develop the technique. Immediately your eye should divide them into three components. You should see like into three components. You should able to visualize them into three components. A good student or a good resident who can able to visualize, put into the picture form. Okay, so now after that you should able to interpret the investigation results. Okay, interpret means, for example, if the hemoglobin level is given, right? So you should able to interpret whether the hemoglobin is decreased or increased. Understand? So for that you should know basically normal values of the investigation, most commonly used investigation parameters. This normal values you should know, especially for that is the module you have to develop, that is called professional skills 2. In the I hope in the third year second semester you will be getting that module. Understand? So during that module, don't waste your time. Okay, so whenever you get a time, you have to memorize all the normal values of the certain commonly used parameters. Because nowadays most of the commonly used parameters, they will not say that hemoglobin is decreased or increased. They give the person's hemoglobin value. Understand? RBC's value. Likewise, they will keep on giving the numbers of the commonly used parameters. Even actually for your level, since you have not finished the professional skills 2, I am not using that. When you come to MSK and CNS, I will be giving only the values. Okay, now after that interpretation, then you have to relate the various investigation findings. Okay, so relate means, for example, in that case that they would have given 2-3 investigations. If 2-3 investigations has been given, then it is a complex case. If it is a single investigation, that is the one is going to lead you to get the what is asked in the question, then it is simple case. So usually it will be a mixture of simple and complex case. In the examination, it will be a simple and complex case. So you have to able to know what is the relationship between these investigations. I will give a simple example. Okay, that is a person is having severe gastritis or ulcer, and his investigation showed vitamin B12 deficiency. You understand? So endoscopy is one kind of investigation. It shows ulcer in the antral region, and the other blood investigation shows macrocytic anemia, and serological investigation shows vitamin B12 deficiency. So we have to relate all these three. Because of antral ulcer, okay, because of severe ulcer, then there is a defect in the intrinsic factor, then automatically it leads to vitamin B12 deficiency, that is leading to macrocytic anemia. Okay, see how it is related. Understand? So this investigation finding you should relate. The clinical symptom will be the patient will have vomiting, hemoptymesis, and you will have epigastric pain, severe epigastric pain, and the pain may be severe after the meal. Understand? Or after 2 hours after the meal, the pain will be very severe. So these are the reasons of, this is how we have to relate, this is called relating, relate the various investigations. Okay, then after relating all the investigations, you should be able to come to a conclusion, you should be able to come to a conclusion. Then that conclusion is your laboratory conclusion, that is your laboratory conclusion. Then you have to correlate this conclusion with the clinical feature, with the clinical feature, that is the last one, correlating the investigation finding with the clinical feature. Then you can derive a diagnosis which is from the differential diagnosis, which is from the differential diagnosis, because by seeing the clinical finding you derive 10 diagnoses, you derive 10 diagnoses. Then you do an investigation. Okay, then investigation findings, all the investigation conclusion should be correlated with the clinical findings. Then your diagnosis will be usually within that differential diagnosis, usually within that differential diagnosis. If it is not within the differential diagnosis, this is a complicated case, that is a complicated case where you and clinician will be doing discussion, where you and clinician will be doing discussion, or that case is not going to be good for the patient, the diagnosis is not going to be good for the patient, understand. So this is very, very important. So when you see a clinical findings, understand, and the clinical findings means it comprises of symptoms and signs, it comprises of symptoms and signs. So based on that symptoms and signs, you derive certain differential diagnosis, you derive certain differential diagnosis. Then you order investigation, then you order the investigation. After you ordering the investigation, then the investigation results, the conclusion and the findings, everything you should correlate with the clinical features. Okay, then it leads to the final conclusion, that is called definite diagnosis, that is called definite diagnosis. So this is evidence based diagnosis, this is evidence based diagnosis. Then this diagnosis will be coming from that differentials, this diagnosis will come from that differential diagnosis. Okay, so this is about correlation. So there are 4 steps. One is dissecting the case scenario, then able to interpret the given values, then you should able to relate the investigation findings given in the case scenario, and able to correlate the investigation finding final conclusion with the clinical findings. Okay, if you can able to do all these the 4 things, then whatever the question may be asked, you might be knowing the answer, you must be knowing the answer. So this is the way you should approach the case, especially to this level, understand. Inshallah, when you come to the 6th year, we will be discussing in different format. Okay, so this is for up to the level which you are. So now coming to the let us take a sample and discuss in this format. It's a 45-year-old man presents with painless mass in the neck as shown in the image. Nowadays most of the license exams, okay, Ibn Sina has not developed that much. Okay, so we are not giving color question papers. Okay, so inshallah there will be a stage where we will be soon giving you the color printout. Okay, the question papers will be in color, so that time we will be giving the images, understand. Even histopathology images will be coming in the questions, understand. So now the license exams, all the license exams are providing the clinical images, histopathology images, all the images they are giving, so you should be able to know the images. Okay, now as shown in the image, and it's a 4 centimeter, actually this is a question taken from the Saudi license exam. So 4 centimeter firm movable tumor, and it is identified at the angle of the left jaw. So up to this it is the clinical findings, up to this is a clinical features. Then biopsy has been done, then the tumor showed in the biopsy is a mix of ductal epithelial cells and myoepithelial cells intermingled with myxoid cartilaginous area, which means it's a mixed with epithelial and myoepithelial cells along with cartilage areas, along with cartilage. It's a investigation finding, it is a investigation finding, and they removed the tumor surgically. Okay, now let us divide the case. It is a 45-year-old man presents with a painless mass in the neck. That is the case history. The patient comes to you and tells that there is a mass in the neck, and then you see a clinical examination. Okay, so what the patient says is the symptom, what you see is the sign, what you see is the sign, and it's a, so when you see, you measure the tumor and you see the consistency of the tumor, you see the consistency of the tumor, the consistency of the tumor is firm and size is 4 centimeter, and you see the mobility of the tumor, you will be seeing the mobility of the tumor, and it is movable, which means it is not fixed and it is freely mobile, and it is freely mobile. And location of the tumor, it is located at the angle of the left jaw. In the clinical picture, it is elevating the ear lobule, it is elevating the ear lobule. So this is the second component, clinical examination findings. Then laboratory investigation is a third component, that is a biopsy. Very straightforward case this is, it's a biopsy. Then the biopsy result they gave, they didn't give the picture of the biopsy, understand. So in other exams they give the histopathology picture and the clinical picture, and they will say the below image shows the histopathology of the tumor. So then you should know what is exactly in the morphology, then you should able to relate it with the clinical findings, correlate with the clinical findings. So this is the laboratory investigation. Now you can see that in this case there are three components. In this case there are three components, that is clinical examination finding and the clinical exam, case history, then clinical examination and the laboratory findings. Okay, now these are the findings. So what you can do, a conclusion is it's an adult case, painless and mobile tumor in parotid gland, and histopathology report shows it's a mixed tumor with no, they didn't give anything about cells nature here, okay, which means the cells are benign, the cells are no atypical cells, no pleomorphic cells, there is no abnormal mitosis, okay, there is no evidence of cancerous change here, there is no evidence of malignant change here, okay. This is the conclusion we came in this case. So after that conclusion, come to a brief name, that is a benign parotid tumor of mixed type, benign parotid tumor of mixed type. When you see this case, this should be your single line conclusion of this case, it's a benign parotid tumor of mixed type. Okay, now coming to the what is the definite diagnosis. Now we have to look into the choice, because the question is about what is the definite diagnosis, right? You have to answer the question here, right? So now before that you came to a conclusion that it is a benign parotid tumor of mixed type. Now what is the question here? It is a what is definite diagnosis? Very simple question it is, okay. It's a what is definite diagnosis, and then we gave 4 choice, okay. So in that 4 choice, how you should think is, see, first thing is a malignant tumor, no need of think there, okay, no need of thinking there. Then second tumor is the Warthin tumor, and third tumor is the pleomorphic adenoma. These both are benign tumor, and the last one is the malignant tumor. In the name itself it's there, it's a malignant tumor. Now in this 2 tumor, one should be the answer, right? Anyway, given the answer, plus concentrate the approach here. So in this 2 tumor, 1 tumor should be the answer, because it's a benign tumor and it's a parotid tumor. Both can come in parotid, If you know the histopathological finding, then you can answer this 2 tumor, because Warthin tumor we didn't discuss in the class, okay, but it has epithelial and lymphoid component, If you know many tumors morphology, then only it confuses, right? So because you know only one, so you got the striking feature, you are coming to the diagnosis, right? But actually when you study more, okay, when you go to license exam, you will be having more knowledge, right? So this all the knowledge will be tested there, So how, that's what I am telling you how to approach this case. So now you excluded 2 choices because it is malignant, So now your choices should be between 2 and 3, right? That is B and C. That is 2 benign tumor are given. If you know this 2 benign tumor, in license exam and all, we don't ask you most uncommon things, understand? Most common things and most important things only we ask in the license exam, whereas in any examination. So The most commonest is pleomorphic adenoma and Warthin tumor. Most commonest is pleomorphic adenoma followed by Warthin tumor. So these two tumors morphology you should know. These two tumors morphology you should know. So pleomorphic adenoma, it is a mixed tumor of epithelial and myoepithelial cells, and it has another component, that is cartilage or bone or some component will be there. So it is a parenchymal and mesenchymal component. It is a benign tumor. As per morphology, it is a benign tumor, and Warthin tumor will have epithelial plus lymphoid component, lymphocytes, and it has a epithelial lining. Bottom will be full of lymphocytes. So it is totally two different morphology. When you compare this morphology, so it is a pleomorphic adenoma. It is a very straightforward case. So now let us go to the next case.
How did you know that benign from the case?
Yeah. Now coming to the reason for benign, because why I classified them into benign and malignant is because in the choice they given two cancerous tumor, two benign tumor. Okay. So now I have to decide whether I am dealing with a benign or cancerous before going to the what is the tumor. This is a stepwise approach to the benign tumor. How we classify the tumors? First it is benign or malignant. So here the choice they gave is two benign and two cancerous, right? So now if the tumor is cancerous, it will be fixed. It will be when you do a clinical examination. So we derived from here. Understand? From the clinical examination, it is so I explained here. Movable means it is freely mobile. It is freely mobile and it is not fixed. So it is a clinical examination finding helps me to derive that it is a benign tumor. I am dealing with most probably of benign tumor. Understand? Most probably of benign tumor. It's not confirmed. But then I go to the biopsy. In the biopsy, I see tumors reveals mixed epithelial cells and cartilaginous area. Nowhere they mentioned about the cell morphology. If it is malignant, they would have explained about cell morphology. The cell morphology, they will explain about the cancerous cell morphology. What are the cancerous cell morphology? Pleomorphism, increased nuclear cytoplasmic ratio, and mitosis, abnormal mitosis. These are the evidence for cancer cells. Okay, these are the morphology seen in the cancer cells. None of the things are mentioned here. So it shows that it is a benign tumor. And that's why we came to a conclusion that it is a mixed tumor with no atypical cells. Atypical cells means cancerous cells or invasion. There is no invasion. Understand? Another evidence is, see, there might be some cancer, some carcinomas. The cells look benign, but they will be invasive. Understand? So that is called well differentiated carcinomas. We discussed in the POD. It is called well differentiated carcinomas. Understand? So that's why both the points are important. The cells appearance and the invasion. Okay. So this will help you to know whether it is a benign or malignant. So clinical findings also suggestive of benign, and histopathology findings confirms it is a benign. So now we came to it's a very easy case, and it's like a eating cake. Okay, so it is very simple case. Now coming to the initial slowly you start discussing more about cases, then automatically it's about practice, how you practice yourself. Okay, then you will be seeing when you see a case, automatically your brain splits them into components. Understand? Then you can come to a conclusion. Now it is a case of 40-year-old man. So these cases and all I want to discuss. So I'm not discussing like first case. Okay, I want you to interact. So 40 years old man, complaints of difficulty in swallowing and tendency to regurgitate his food. It is a clinical case history or it is a clinical examination? Anyone can say? It is a history. Right? Because the patient will come and tell, because we cannot find this difficulty in swallowing, right? So the patient will come and tell you that he is having difficulty in swallowing. How you clinically examine that? If the person, for example, Huda is coming and telling me that she is having difficulty in swallowing, How you will trust her? Okay, just I'll give a water and I'll ask him to drink. Understand? So that is the one kind of examination we do for swallowing. Understand? So inshallah in the clinical side they'll explain you more. So now so you all know that difficulty in swallowing, we have two types of difficulty in swallowing, right? So one is what is that? One is forget about functional mechanical here. Please tell me what depends upon the content of the food. Content of the food, right? For example, if they can't able to, we ask them whether it is a solid food or it is a fluid. Whether it is a fluid, when you consider it is worse. If they can't even the liquid, we consider that dysphagia is very severe. Dysphagia is very severe. Okay. If the patient is having pain during dysphagia, what do you think? What is the name? Odinophagia. It is given a name called odinophagia. Here the patient is having only difficulty in swallowing. Only difficulty in swallowing, and he is having regurgitation. He is having regurgitation. Okay. So this is about his case history. Then they didn't give us any examination details. They didn't give us any examination details. They went to the endoscopy. They went to the endoscopy. Endoscopy doesn't show any esophageal or gastric abnormalities. Okay, there is no any abnormalities detected in endoscopy. Manometric studies means they study the movement of the intestines. They found that there is absence of peristalsis, failure of lower esophageal sphincter, and to relax upon swallowing. So the lower esophageal sphincter is not relaxing during the swallowing, and there is an increased intraesophageal pressure. Okay, because you are taking the thing and it is not going down, so it will increase the pressure in the esophagus. Okay, now go to the handout. Okay, go to your handout of esophagus. Just you find where it is. Okay, and if you go to your handout, these clinical findings will be given in the clinical features. Nobody is having the handout. Go to the handout means I am not telling someone outside. I am telling you guys. Huh? Yeah, let us discuss. So go to your handout. Okay, because I want you guys to understand where these components are in your handout. Okay, that is very important, so that if you study, you can think and study like this. Okay, the clinical findings, okay, which is coming in the first line of the case or second line of the case, it will be there in the clinical features of the handout. Clinical feature of the handouts. Understand? Then endoscopy findings or the histopathology findings you will be seeing in the morphology. Investigation findings, please listen. Okay, and don't irritate me. So investigation findings you will be seeing again in the clinical features. You will be saying even in the clinical features. In some of the modules we give it as a separate. Okay, for example, hematology module we give it as a separate heading. So you should know where these clinical findings are coming from the handout. These clinical findings are coming from your clinical features given in that disease. Okay, now here it is difficulty in swallowing and regurgitate. Most of the esophageal diseases have this finding, right? Most of the esophageal diseases have difficulty in swallowing and regurgitation issue. So it is very non-specific. It is highly non-specific, which means they are going to tell some specific things in the investigation. That's what you should understand when you read the first line. Don't get panic, which means that the clue is going to be there in the investigation. Okay, now endoscopy doesn't reveal any changes, doesn't show any changes. Okay, which means forget about all the morphological diseases of the esophagus. Okay, now it must be, then they told about mammometric studies. Okay, whenever they talk about mammometric studies, ECG, electroencephalogram, electrocardiogram, electromyelogram. These are the things tells about functions. These are the things tells about functions of the organ. So mammometric studies. So ECG tells about what? About the cardiac function, right? About cardiac contraction, electrical function of the cardiac muscle. Likewise, mammometric studies how the intestine movements are happening, how the intestinal movements are happening. So first clue here comes is complete absence of peristalsis, and lower esophageal sphincter is cannot able to relax, and there is a increased esophageal pressure. Now even you can refer the handout, take your time and tell what is the most likely diagnosis. Achalasia, Barrett's esophagus, esophageal stricture, and Malaria syndrome. So what is the, see, two are completely very distant distractor. Okay, see, there is a, in this four choice there is an answer. In the four choice there is an answer, and others are all distractors. Understand? So the key is the answer and others are all distractors. Whenever the choices are having distractors away from the answer, okay, then answers will be very distinct. It is like a what to say, twinkling star there. Understand? You can characteristically see the answer if the distractors are very away. So when you go to your studies in higher level, the distractors will be kept very close. The distractors will be kept very close. For example, you are going for residency exam. So residency is about that specialty. For example, you are doing residency in histopathology. That time, when we keep histopathology examination, we keep the distractors very close. So if you are very much thorough with the answer, only you can answer. Understand? So the distractors, all the four answers look same. Understand? So very thin thread line will be there between the this distractors and the answer. Okay. So for us also to develop such question is very difficult. Understand? If you ask me to develop question, because we send questions, I am also a external reviewer for many license exams. So we send questions to them. Okay. For us to take one question, it will take 1 week time. Understand? So to develop such questions is also difficult for any examiner. So, but for your level, we don't keep very close distractors. Okay, we try to keep 2 or 3 close distractors, and usually it will be 5 choices. Okay, here it is 4 choices. That is another disaster thing here. So, and so now within these 4 choices, okay, so what you can see is there are 2 answers are very near to that, and 2 are away from that. Okay, only thing is Barrett's esophagus is given to confuse us with the regurgitation, and Malaria syndrome is really meaningless distractor here. Understand? So because it is very nowhere it is related to this. Okay, there is no history of alcoholism, there is no history of any the patient is having any chronic other illness to have a Malaria syndrome, because Malaria syndrome most commonest thing is the patient should have a chronic illness or chronic alcoholism, right? Chronic alcoholism. So now Malaria syndrome is excluded. Okay, now Barrett's esophagus is also excluded because it will not cause peristalsis. Okay. Now only two kinds of obstruction comes here, and because they are not, other two are non-obstructive disease. Barrett's esophagus or Malaria syndrome, they are non-obstructive disease. Actually, Malaria syndrome they kept as a confusion to confuse you, because it is only fool will get confused in this scenario, because you all know that Malaria syndrome, the sphincter becomes very tight during reverse peristalsis. You understand? Not during peristalsis. So Malaria syndrome, they want to confuse you, because whether we know the concept of reverse peristalsis or peristalsis, even though distractors are distant, that they will not keep meaningless distractors. Okay, especially in our department, we will not keep meaningless distractors. Understand? So what you have to understand, the concept here is peristalsis and reverse peristalsis. Malaria syndrome, the sphincter is tightly closed because of reverse peristalsis. So the reverse peristalsis will not happen the sphincter will forcefully open, it produce tears. It produce tears. You understand? Now they will not cause obstruction. However, they will not cause obstruction. Now there is obstruction because this is the one tells us there is obstruction. Increased intraesophageal pressure. Okay, if there is no obstruction, intraesophageal pressure will not increase. Okay, so there is some obstruction, that's why the pressure is increasing. So only the obstructive diseases you should think. Two things can cause obstructive diseases. One is achalasia, other one is esophageal stricture. Esophageal stricture means the fibrosis happening in the esophagus. Fibrosis happening in the esophagus, and in the fibrosis happening in the esophagus, that will not affect the peristalsis. That will not affect the peristalsis. Here the peristalsis is affected. Complete absence of peristalsis. So it is some functional obstruction. It is some functional obstruction. Esophageal stricture, it will cause only mechanical obstruction. It will cause only mechanical obstruction. So achalasia is a functional obstruction. It is a functional obstruction. So it is one of the most commonest disease we see in the very late adult or even in the children. Even in the children. So it is called achalasia cardia sometimes because because of the peristalsis they give the name, because the problem happens in the lower end of the esophageal sphincter. Okay, now it is called achalasia. You understand you got the approach of this scenario?
Yeah.
So first of all, you are seeing you are trying to divide into three components. The first component, what you are seeing is only the case history. There is no clinical finding. There is no clinical finding. Okay, second component is missing, which means there is going to be very direct clue in the investigations. There is going to be direct clue in the investigations. And the first they mentioned you about endoscopic findings, where they mentioned you about everything is normal. Understand? Okay. Then they mentioned about manometric studies, where the function of the esophageal movement is told. That is no peristalsis, peristalsis, right? And the sphincter tone is strong. The sphincter tone is strong, and there is a increased pressure in the esophagus. Increased pressure in the esophagus. So why the endoscopy is negative? They are telling there is no mechanical obstruction. There is no mechanical obstruction, and they are talking about functional studies where there is peristalsis. So that itself gives a clue that you are dealing with functional obstruction. You are dealing with functional obstruction. From that clue also, if students are very clever, they can choose achalasia directly. They can choose achalasia directly. But however, don't jump into that. That's what I always tell. Most of the times we do this mistake. Okay, we got the diagnosis before seeing the choice, and we jump into the diagnosis. Then if you read the all the choices, then you will get confused with one or two choice. Okay, so that is the area where you have to think. Understand? So always don't jump into that. Sometimes it will be very straightforward, simple case scenarios. So but always read all the choices and then exclude all the choice in a minute. Then you come to the diagnosis. Come to the diagnosis. Do the method of exclusion. Without doing the method of exclusion, you will end up with grave mistakes. You will end up with grave mistakes. From the exam, you will come out and somebody will tell that is not a choice. But because you didn't see that choice, because you would have marked the wrong answer. Okay, so this is about approach towards this case. What's your here there is nowhere it mentioned about details of the biopsy. Details of the biopsy. Okay, when they give about details of the biopsies, then you can rule out Chagas disease, or any history is given, like for example the patient went to Spain, or the patient went to South America, okay, or the patient went to that Indonesia, that side. Okay, these are all epidemiological details they will give. Okay, so it will give you a clue towards whenever they are giving epidemiological details, whenever they are telling the patient travel to this country, which means that it is because inshallah you will develop that art. Okay, it is a sign that they are talking about some infectious disease. It is a sign that they are talking about some infectious disease. Usually they will give, when I am going to target Chagas disease, trypanosoma, then I will give a history of South America. Okay, the patient recently traveled to South America and came, like that I will be giving. Okay, so it is a case of achalasia. It is a very simple case. Now coming to the case discussion number 3. Now it is a 30-year-old man he already been diagnosed of AIDS. He is having severe pain on swallowing. So what is the name? It is a odinophagia. It is a case of odinophagia, severe pain on swallowing. Okay, now this is about the patient history. This is about patient history because they given adult man with a past history. He is having they been diagnosed of AIDS, and he is also having now pain in the during swallowing, odinophagia. After that, they didn't give any examination. So upper GI endoscopy shows elevated white plaques and hyperemic and edematous esophageal mucosa. Okay, so surrounding the plaques there is more blood vessels and it is edematous. It is edematous. It is a sign of inflammation. It is a sign of, because what is the first sign in inflammation? Vascular change. Vascular change is vasodilation, hyperemia. More blood comes to the area. Then followed by edema, followed by local edema. So it is a sign of acute inflammation along with some white plaques which is also elevated, which is also above the mucosa. Which of the following is most likely diagnosis? So why it's not Barrett esophagus?
Because there is a sign of inflammation and edematous.
What is the characteristic endoscopic feature of Barrett's esophagus? Endoscopic feature of endoscopic feature. It's not microscopic feature. Okay, what is the color? Yeah, it is red velvety appearance. Here it is exactly opposite, right? It is elevated white appearance. So completely it is ruled out. Okay, Barrett's esophagus is excluded. Okay, now let us discuss squamous cell carcinoma in situ. Okay, yes, of course it could be of squamous cell carcinoma in situ because it is a elevated white plaques. It could be of leukoplakia. It could be of leukoplakia. You understand? So leukoplakia may hold dysplastic situations. It may hold carcinoma in situ. Okay, there is a question here. So reflex esophagitis, it will not cause pain in during the swallowing. Okay, so it is ruled out. Now only the confusion is Candida esophagitis and squamous cell carcinoma. So it is a AIDS patient. It is a immunocompromised patient. So even in immunocompromised patient you can get squamous cell carcinoma. Even you can get Candida infection. And pain during swallowing. Okay, pain during swallowing can be seen during squamous cell carcinoma as well as candidal esophagitis. So now elevated white plaques, and in squamous cell carcinoma it will be ulceroproliferative lesion. It will be ulceroproliferative lesion. It will not be just like a elevated plaques. Okay, there will be ulcer and as well as growth. There will be ulcer and as well as growth. So with that, this is the diagnosis. This is not a diagnosis. Understand? So like this you should able to exclude. Okay, you should know about all other diseases to exclude. Understand? Then only you can able to conclude. Understand? So then your conclusion will be your answer. Okay, so don't, if somebody is directly concluding, he may do right this time. Okay, when the real case comes to him, he will do a blunder. Okay, so that's why in West Indies and all, when the people actually we do give a explanation notes here after the each question. They have to explain why it is correct, why others are not correct. Okay, if their choice is there. Okay, anyway we are not troubling you that much. Okay, so now you have to understand, when this is the right way of approach, you should be able to exclude, then you should be able to conclude. Okay, if you are concluding without seeing the things, then you may do gross errors, not now maybe or in the future. So now coming to the case discussion number 4. Now it is a 58-year-old woman. She brought to the emergency department 4 hours after severe vomiting of blood and experiencing bloody stools. Okay, now it's a patient history that she brought to the emergency. Usually who is accompanying that patient, they will tell this. Okay, The patient was vomiting continuously for 4 hours and she also had bloody stools. Okay. Now the patient was diagnosed with, this is the from her past history, diagnosed with alcoholic cirrhosis 2 years ago. Alcoholic cirrhosis 2 years ago. The patient goes into shock and died. Okay. What type of shock? It is a hypovolemic shock. Hypovolemic shock, because the patient went for vomiting and bloody stools, the blood volume will be reduced, and hypovolemic shock that would have created multi-organ failure and the patient died. Now they did the histological examination of the esophagus during autopsy and they found esophagus having dilated blood vessels and ulcers. Which of the following is the cause of hematomesis, hematochezia, which means a bloody stool in this patient? Okay. Now first you have to rule out all these 4 and you have to exclude 3 and you have to come to a conclusion, right? So first of all, alcoholic hepatitis can cause hematomesis and hematochezia. Now they given alcoholic cirrhosis. Okay. Alcoholic cirrhosis, if it is given, it can cause hematomesis and hematochezia. Okay. It can cause bleeding, blood in the vomit as well as blood in the stools. Okay. Why you are ruling out? It is not alcoholic steatosis, alcoholic hepatitis. See, alcoholic hepatitis can cause cirrhosis. Cirrhosis can reduce synthesis of clotting factor and they can bleed.
But he diagnosed from 2 years.
Yeah, whatever it may be. 2 years he is cirrhotic. Now it is becoming worse. All the liver is spoiled. All the liver is fibrotic. Now they cannot able to synthesize enough clotting factor. So they are going for bleeding. Mashallah. So here the pathology they are checking to is dilated blood vessels in the esophagus. Okay. So of course it is happening due to alcoholism, but they cross the stage of inflammation. They cross the stage of inflammation. It is not alcoholic hepatitis. If they are given alcoholic cirrhosis, then it would have been the right answer. Understand? So it is a only they given as a alcoholic inflammation. Okay. It is not only inflammation. It is more beyond that. Beyond than that. Now portal hypertension. Okay. So portal hypertension is a consequences of alcoholic cirrhosis. It is a complication of alcoholic cirrhosis. What are the things happens in portal hypertension? What are the things can happen in portal hypertension? So splenomegaly can happen, ascites can happen. Okay. Okay, hydrothorax can happen because of the severe ascites. Mashallah, esophageal varices. Okay, so one of the complication of portal hypertension is esophageal varices. Even hemorrhoids will come. Even hemorrhoids can happen. Understand? So in this case, if you would have seen the hemorrhoid vessels, okay, that also would have been dilated. That also would have been dilated. Understand? That's why the patient is bleeding in the rectum. Bleeding in the blood stools are coming because of the rupture of the hemorrhoids. Rupture of the hemorrhoids. So likewise, they can produce dilation of blood vessels in the collaterals in the esophagus, lower end of esophagus. So that will rupture and the patient will bleed. Massively they will bleed because they don't have a capacity to clot. They don't have a capacity to clot because of cirrhosis. They don't have enough clotting factors. They don't have enough clotting factors. So that's why it could be most probably a case of portal hypertension, but we have to rule out other 2 things. Okay. Now Malaria Syndrome, it will not produce this kind of bloody stools. Okay, they cannot produce bloody stools, and esophageal findings is not showing any longitudinal ulcers, but Malaria Syndrome will not have dilated blood vessels. Will not have dilated blood vessels. They have only longitudinal tears, not ulcer. Longitudinal tears. So it is excluded. And now peptic ulcer disease. Okay. Peptic ulcer disease, they didn't mention anything about endoscopy going to the gastric or duodenum. So they didn't give any findings related to the peptic ulcer disease. So only any history is favorable of peptic ulcer disease. Actually vomiting, blood vomiting can come in peptic ulcer, and even some bloody stool can occur in peptic ulcer. But it is not related to the alcoholic cirrhosis. It is not related to the alcoholic cirrhosis. With that finding, we are ruling out it is not a peptic ulcer disease. So it is a case of portal hypertension. Okay. So in the portal hypertension, you should able to, even though the case is very direct, but you should able to think of all the things about portal hypertension. Okay. So it can produce ascites, it can produce organomegaly, and it can produce hydrothorax, and it can produce dilation of the blood vessels in the esophagus. It can produce dilation of the blood vessels in the hemorrhoids. Now, discussion number 5. It is a 35-year-old man with a 5 months history of weakness and fatigue. Okay, very blind history. Okay, so the patient is weak and fatigue. What is the difference between weakness and fatigue? Take it as a homework. Please find me the answer. Okay, what is the difference between weakness and fatigue? Actually, I will not remember this homework, okay, because I am taking a lot of batches. If people interested person can email me, and interested person can come and tell me. Okay, so some of the students usually communicate through email. Okay, so it's like a confirming your answer, as well as I will appreciate you. So now 34-year-old man have a history of weakness and fatigue, and there is no history of drug or alcoholic abuse. The patient is complete blood count, okay, CBC, shows megaloblastic anemia, and normal reticulocyte count, and the patient laboratory studies also revealed vitamin B12 deficiency. Anemia in this patient is most likely caused by which of the following? Here I am actually asking the pathogenesis. Okay, so now what are the reasons could be of vitamin B12 deficiency? Okay, in this background, okay, the patient is not having any drug intake, there is no alcoholic abuse, and the patient is producing not even bloody vomiting or anything. Okay, just he is weak and he is fatigued, and the laboratory features telling about megaloblastic anemia, that is due to vitamin B12 deficiency. What is the reason for anemia? That is a simple question. What is the reason for anemia in this case, in this background? So the given choice: acute erosive gastritis. Does it fit? Why?
Because it's not produced Galactic.
See, I will tell you why. There are certain things. Okay, first you tell me why from the history.
Doctor, it's 5 months. If it's
Yeah, why there is a lot of gastritis having 5 months, 1 year of history.
no history.
Yeah, no history. Okay, so no history of drug is a major clue here for rule out in the acute erosive gastritis. Understand? Because NSAID and aspirin are the most commonly used drug to cause acute gastritis, acute ulcerative gastritis. Now it is ruled out. Okay, because the patient doesn't have any drug history. Patient doesn't have any misuse of drugs. Okay, now coming to the peptic ulcer disease, the peptic ulcer disease will not produce vitamin B12 deficiency or megaloblastic anemia. Next is Helicobacter pyloric gastritis. Again, they will not produce any vitamin B12 deficiency or what to say, megaloblastic anemia. So now the pathology directly talks about autoimmune gastritis. Why it is happening? Because they destroy the parietal cells, and sometimes they will destroy only the intrinsic factor. Okay, that is called pernicious anemia. Okay, so sometimes they destroy only the intrinsic factor, so that will leads to severe malabsorption of vitamin B12. Okay, then it leads to vitamin B12 deficiency that reflects in the RBC as megaloblastic anemia.
What's the difference between megaloblastic anemia and pernicious
Megaloblastic anemia and
anemia?
pernicious anemia. See, megaloblastic anemia is morphological diagnosis. It's a morphological diagnosis. For example, normal RBC is 7 microns in size. 7 microns in size. If the RBC becomes more than 7, it is called megaloblastic. It is called macrocytic. It is called macrocytic. If it is become small, it is called microcytic. So macrocytic anemias are otherwise called as megaloblastic anemias. On morphology, it may be due to many reasons. Okay, it might be due to many reasons. If it is due to antibodies for intrinsic factor, okay, then it is called pernicious anemia. Okay, so megaloblastic anemia can happen due to many reasons. Inshallah, that we will discuss in a separate lecture in hematology module. So now it is a pernicious anemia is due to the antibodies towards the intrinsic factor that will destroy the intrinsic factor. Okay, now in the blood also we do an investigation to see antibodies for intrinsic factor. Okay, so if that is also elevated, it is a evidence that it is a pernicious anemia. Okay, now it is a sixth case. Now 21-year-old man is brought to emergency due to acute intestinal obstruction. Okay, so acute intestinal obstruction always comes as an emergency, always comes as a severe emergency, and the patient temperature is mildly elevated and respiration is 25 per minute and blood pressure is nearly normal. So physical examination reveals a mass in the right lower abdominal quadrant. Where is right lower abdominal quadrant? Okay, so in the cecum, terminal ileum and the right side colon. Okay, all the areas we call right lower abdominal quadrant. Okay, now the patient subsequently undergoes surgery. A segment of lesion involving the terminal ileum is resected. Okay, a segment of they found. Actually, I want to put the word actually laparotomy. Okay, they don't do exact surgery. They open the abdomen and they see what is there in the abdomen. Okay, when they see what is there in the abdomen, they found the ileum is having some skip lesions and some creeping fat. Okay, then they removed that and they sent for histopathology and it shows non-caseating granuloma in all the layers of ileum. What is this? Very straightforward diagnosis. What is your diagnosis? Sir? Crohn's disease. Because rest of only the thing which can confuse you is ulcerative colitis. Ulcerative colitis will not have granuloma. Okay, will not have granuloma, and it is mucosal and submucosal inflammation, whereas Crohn's disease is a transmural inflammation. Okay. Now these are all both are carcinomas, just to confuse you with light lower quadrant pain, because this also comes in and produce the right lower quadrant pain as well as intestinal obstruction, Somebody is giving this kind of case. Okay, it is very straightforward, which means that he wants to test you whether you know the histopathology. You know the histopathology. It's not like to test you whether you know to correlate.
Doctor, also creeping fat, right?
Yeah, creeping fat is a characteristic feature of Crohn's disease. Now it is a 50-year-old man with a long-standing alcoholic cirrhosis, and he developed abdominal pain, fever, and episode of hematemesis. Okay, this is all case history. And now physical examination revealed jaundice and distended abdomen, which means jaundice and ascites. The patient is disoriented. Tremors are seen. Okay, which means some CNS involvement. Okay, let us see what is lab. Lab features are elevated, okay, alanine transferase and aspartate transferase, aminotransferase enzymes are elevated, and high serum level of alkaline phosphatase. Prothrombin time is prolonged. WBC is showing increased, and the patient developed coma and adult respiratory distress syndrome and renal failure. Okay, serum levels of creatinine and blood urea nitrogen, everything is elevated. That is a sign of renal failure. The patient died in 3 days. Okay, so what histological examination of the patient kidney or autopsy would most likely show which of the following? First of all, you understand the case. Okay, it's an alcoholic patient, went for cirrhosis. Now he is coming with severe jaundice and ascites. After coming, the patient has disoriented and tremors, which means CNS involvement. Okay, and all the enzymes are elevated. Okay, which means the patient develops prolonged prothrombin time, which means the liver function is affected. Liver function is severely affected. So because of that, the patient developed, and creatinine and blood urine nitrogen is also elevated, right? So he developed hepatoencephalopathy, he developed hepatorenal syndrome, and he got acute respiratory distress illness, okay, that is hepatopulmonary syndrome. He developed all these three, understand? The patient died. Now they took a renal biopsy to know what is happened in the kidney, okay, what are the changes you can see, okay. You will be seeing no histological changes because there is no morphological disease in the kidney. It is only affecting because there is a arteriolar vasoconstriction, decreased GFR, okay. So you should know why I am telling this pathogenesis is, they may ask you what led the kidney to go for decreased GFR, understand? So you should know that there is a arteriolar vasoconstriction, there is a arteriolar. See, this is a very easy question, okay. For example, if you want to ask little bit confusing, they may ask you, instead of asking what will be the histopathology feature of the renal biopsy, they can ask you what is the reason for hepatorenal syndrome, okay. You should know, or what is the reason for increase in serum creatinine, understand? Then you should know about complete pathogenesis, understand? So don't think that it is very easy. Just one question can change the perspective of the question. What is the reason for, I am not telling about hepatorenal syndrome, I will ask what is the reason for increase in serum creatinine. So decrease GFR, decrease GFR. What is the reason for decreased GFR? If I ask, what you will write? Because of arteriolar vasoconstriction. What is the reason for arteriolar vasoconstriction? Then you should say increase estrogen level, increase peripheral vasodilation, increase peripheral vasodilation. That's what, this is how we ask the question. If I want to target pathology, histopathogenesis, I can target in the question. I can if I want to target about investigation, I can target in the questions. Okay, just I have to change the same case scenario. I can change the question. I can bring a new perspective. You got my point? Okay, now same question, same scenario. Okay, same scenario. I may ask you, what is the reason for disorientation and tremor? Shall I increase ammonia? Understand? So what will happen if there is increased ammonia? I am giving serum ammonia is elevated in this case. I didn't give the serum ammonia. What? No, actually let me complete the question. So I am giving that serum ammonia is elevated. Okay. Now I am asking a question. What is the reason for, what kind of damage it causes, because of what kind of damage it causes in the central nervous system because of increased ammonia? You understand my question? Please try to understand my question. What kind of damage happens in the central nervous system due to increase in astrocyte swelling, understand, astrocyte swelling, and defect in the neurotransmission, okay. So this is the reason for coma in this patient, okay. Likewise, we can change this question and we can ask the pathogenesis, okay. Once again, to since I am going to conclude now, please understand the clinical history and the clinical features will be there in the corresponding clinical findings of the disease in the handout, and the investigations and morphological findings, what we are telling in the laboratory investigations, that will be seen in the morphology and the clinical findings of the handout, okay. So then we ask you about what is the diagnosis. Based on this correlation, you can come to a diagnosis, or we will ask you why it is happening. Okay, if you ask us what is the reason, that is how it happens, that is mechanism, okay. Why it is happening, that is etiology. So how it happens is the reason for happening, that is mechanism of the disease. Why it happening, why there is change in the mechanism, because of some cause, some etiology. So this is how we target the questions. See, this is how that we train the examiners when we are asking them to prepare questions, Understand? Actually, I am telling the secrets here. Understand? When we train the examiners, we tell them, this is the same verbatim word I use when I am training the examiners. So we tell them how to frame the questions, how to target the diagnosis, how to target the investigation procedures, how to target the recovered investigation. For example, this is the, please listen Yani, because very most important thing I am discussing for your life. See, for example, same scenario, okay, I will I will not say the patient died. The patient is admitted in the ICU for evaluation of coma. What investigation you do in this scenario to rule out hepatic encephalopathy? Mashallah, serum ammonia. Okay, see how I am changing the, you understand, same scenario I am putting lot of questions to know the intricacies of the case, to know the details of the case. So don't get panic when you see a case. Okay, so go stepwise process as I mentioned. See, this is how we train the examiners to ask you the question. Understand? There is no secret between examiner and you. Understand? So this is how you should approach these things in your life. Okay, so same question I can, same scenario I can ask even 100 questions. If a good examiner is there, same scenarios I can ask even 100 questions is maybe too much. Okay, 20-30 questions I can ask. Okay, so and in Arabic also, right, when I say 100 means it is more number of questions. I didn't mean verbatim 100. Okay, so 20-30 questions I can ask in the same scenario. Okay, so please understand, today just early morning, Alhamdulillah, I finalized the questions for GAT. Okay, so with that freshman I discussed. Okay, I saw purposely I have a multi monitor. I put PBL, N block, N semester, PBL and resit and these questions. I saw to that none of the things are repeated. Okay, I'm frankly telling, because I'm very much keen on fearing Allah and integrity of the assessment. Okay, don't have this kind of foolish ideas that these questions will be asked. Okay, and that's why I'm emphasizing, because I know, mashallah, you all the students will not do that. Those who didn't come, okay, those who are hearing this video, especially males, okay, they may think that these are the questions are discussed so that it will come in the exam. Understand? So one, this is the wrong attitude been spreading in Ibn Sina. Okay, and one day these videos will be selling in Andalus Mall or Andalus Street or in opposite to college, in the shop they may sell this video also. Understand? But please remember, these questions will be, these cases will be never asked in any of the exams in Ibn Sina this year or in the future. Understand? So please understand that while I am telling, I have a capability to take different questions from the same scenario. Understand? Alhamdulillah, Allah gave me opportunity to get trained from the great scholars. So keep that in your mind, and this is the best thing I can do for you guys is how to interpret this case scenario based approach towards the case scenario based MCQs. Any doubts? Yes, one by one. Yes, Sudha.
Ammonia, when it separates, it will cause
Hello. Yes. Yes, brother, I'm in the lecture, brother. Call me after 12 o'clock. 12. Yes, tell me, Huda. Huh?
I want to know after sight. No, they give.
Okay. Well, who is? Huh? I think 3 questions for PBL, 7 questions for N block, and seven questions for N block, 10 questions for N semester. Reseat also 10 questions. Okay. Anybody is having any questions? It's clear? Okay, I'll close the video.